Accuracy of digital technology in TKR. In our quest for full function, coupled with long-term survivorship, the role for digital technology in TKR is increasing. Various digital interventions have come in to augment surgeon skills in TKR. It is important to understand each of these and the principles on which they work to understand their accuracy and their shortcomings. It is only then that we can understand where we have come from and where should we be going. The Australian Registry 2019 shows that more than 130,000 primary TKRs in Australia were computer navigated. This meant that at least one out of the three primary TKRs were aided by computer navigation. As can be seen in the graph, the percentages are going up year on year. Another 12.2% of all primary TKRs had image-derived instrumentation, or what is popularly known as patient-specific instrumentation. So when we add up, almost half of the primary TKRs were aided by technology, and there is no run away from the fact that digital technology in TKR is here to stay. Amongst the various diverse digital technologies available, the one having the longest track record is computer navigation. It is followed by image-derived instrumentation in form of 3D printed patient-specific cutting blocks. Robotics has developed along two pathways, one with haptic arm and the one without. Also, data input for robotics has developed along two pathways, image-based, where there is a CT-based registration, and image-less, where there is computer-navigated registration. And finally, the new kid on the block is 3D augmented surgery, which is image-based planning with modular reusable image-based instrumentation. If we take a deep dive into the principles of technology, we understand that computers are at the very heart of this digital technology. The functioning of the computer can be divided into three basic steps: data input, data processing by the central processing unit, and data output. As the bone is a hard structure with fixed coordinates which do not change its relationship from image capture to execution of surgery, it lends itself to computer technology. The data input can be done either preoperatively in form of imaging, or it can be captured live at the time of surgery. As we understand with computers, it is the quality of data input which determines the output. What are the determinants of data input? It is the quality of image capture and landmark identification, which is then processed by the central processing unit, which then gives us precision in the output, which is a bone cut. An error in sum total of a column in the spreadsheet requires only two verification checks: whether the data entry is correct or that the correct data set has been marked for totaling. It is immaterial whether the CPU of the computer is an old 486 chip or the latest Core i7 processor. It is immaterial whether the RAM of the computer is 1 GB or 32 GB. Similarly, with the minuscule amount of calculations in actual computing terms required for performing a TKR, the processing speeds or the accuracy of the computer do not affect the results. It is the quality of data input, quality of image capture, the data entry, or the accuracy of landmark identification. Any garbage at the time of image capture and landmark identification will lead to garbage in bone cuts. So, the primary determinants of accuracy are quality of image capture and landmark identification. Image capture can be by three means. X-rays, we know that 2D imaging is inaccurate, but lately orthogonal X-rays fed into machine learning algorithms And with help of artificial intelligence and an exceptionally large database, it is possible to find a 3D image close to what the X-rays are showing. However, the 3D image produced isn't the precise custom 3D of that particular patient. It is close to that of the patient. And hence, for the moment, CT scan or 3D assisted MRIs is the gold standard. Imageless techniques relies on the surgeon mapping during surgery. The surgeon might pick up air points as the pointer might slip during registration. Occasionally, soft tissues can mask anatomic landmarks and it could lead to errors in image capture. Thus, it is very operator dependent in terms of operator experience and skill. Landmark identification techniques differ according to techniques of image capture. We have seen that the two popular methods for image capture are 3D imaging and imageless techniques. Hence, errors in identification of landmarks will be discussed under two separate headings of 3D imaging landmark identification protocols and imageless technique landmark identification protocols. For 3D image based landmark identification protocols, the main variable is who is identifying the landmarks. Once again, here too, it is very operator dependent. For most patient specific instrumentation imaging, the landmarks are either picked up by a biomedical engineer or a medical rep. This is not very reliable as studied by the Hoffman group. Surgeon based planning systems have much less error as shown by their study. Newer systems are in pipelines with artificial intelligence and machine learning algorithms, but the accuracy at present does not seem to exceed the surgeon based systems. So in summary of data input accuracy for image-based systems, data acquisition for image capture is accurate to within 1 mm. Landmark identification, surgeon-based systems are more accurate than systems which rely on medical rep or biomedical engineers. In the imageless landmark identification systems, we have seen that point grab errors are unquantified. The landmark identification errors change depending on the landmarks registered, and they vary according to the planes and hence are best studied according to three planes: coronal, sagittal, and axial. How do we identify these errors? The error calculation method is simple trigonometry. The error margin is dependent on the length across which the error is measured. So the degree of error is equal to sine inverse of the distance error in landmark registration divided by the length of the bone across which it is measured. In the coronal plane, because the lengths of femur and tibia are significantly long, the error margin of up to 2 mm will lead to an error of 0.2 degrees only. Thus, with all computer navigated devices, we have excellent post-op coronal plane X-rays. And this is once again borne out by literature. The risk of malalignment in coronal plane is very low. 95% confidence interval is very good. So yes, it is excellent in terms of landmark identification errors in coronal plane. For the sagittal plane, once again, we are measuring across the same length of bone. It is very accurate. The issue is it adequate? Why? Because we know that the femur is bowed and the distal femur flexion angle varies from 3 to 5 degrees. 80% of the knees were within 3 plus minus 2 degrees. In 11.4% Asians, distal femoral flexion angle was more than 5 degrees. So effectively what happens is when we are using a technology aided TKR, we approximate the distal femur flexion to either 2 or 3 degrees. We are not able to judge the flexion of the distal femur, and hence it is not accurate planning within 2 to 3 degrees, even if the computing accuracy of the system is either 0.5 degrees or zero point 0.1 mm. Placing the femur at 0 degree flexion to the mechanical axis will lead to extension of the femoral component with respect to distal femur in 39% of patients. And as we know, extending the femoral component will stuff the anterior offset, leading to pain. And this is borne out by this paper, which is a Chitranjan S. Ranawat award-winning study, randomized trial with a 14-year follow-up. They do not recommend widespread use of computer navigation because of its risks of notching and attendant costs. The issue is not that navigation is bad. It is understanding where errors in navigation occur. For the axial plane, the angle across which this is measured is much smaller, and that is why the error range is much larger. As we can see, a 2 mm error in the coronal plane leads to an error of only 0.2 degrees, whereas in the axial or plane or for rotation, it can lead to an error of 5.7 degrees. So most imageless systems will put the onus on the operating surgeon to allow him or her to choose between any of the markers for rotation, like the transepicondylar axis, the femur AP axis, or the tibial cut surface. It's important to understand that most of the times when we are offered multiple options, it is that none of the options are completely accurate. This was an excellent study wherein they compared CT findings and intraoperative navigation measurements in 70 patients. What did they conclude? Due to inaccurate identification of femoral condyles, the related navigated measurements are considered to be unreliable and irreproducible. Preoperative CT scan is the only reliable method. Thus, most modern digital guiding systems will boast of a calculation precision of 0.5 degrees or 0.1 mm. Yet, what happens is that when there is error of data input with an imageless robot of 0.1 mm accuracy, we have a rotational error of up to 6 degrees. Calculation precision of 0.5 degrees or 0.1 mm is not going to help. It is still going to be garbage out. So calculation precision does not matter. It is the quality of data input which goes into the system. If we were to summarize, in computer navigation, the image capture is imageless, and that is why there can be unquantified point grab error. Landmark selection by the surgeon is accurate for coronal plane. It is accurate for sagittal plane, but the quality of data is inadequate. The surgeon is unaware of the femoral bow, and hence the degree of flexion of femoral component is guesswork only. Also, it is very poor in terms of guiding for rotations. And probably that is the reason why a fair amount of papers say that navigation does not help. It definitely reduces the risk of malalignment, but there is a concomitant 23% increase in operative time. And this was a meta-analysis of 33 studies in which 11 were good randomized controlled trials. With patient-specific or image-derived instrumentation, The image capture is very accurate, but the landmark selection is done either by the company rep or a biomedical engineer. Surgeon is blinded to the results. This is the only digital technology known to decrease operative time with 20% reduction in OR time. But the mechanical axis outliers were similar to conventional. At 9 years, in terms of survivorship, there was not much to differentiate in the Australian registry. But with modern implants, most digital aids would need at least 15 years to show significant improvement over conventional techniques. With imageless robotics, the surgeon defines the landmarks during surgery. So point grab errors remain. Coronal plane, once again, is very accurate, but it follows the principles of navigation. Hence, it is accurate for sagittal plane, but it is inadequate and it is consistently poor in defining rotation. For image-based robotics, image capture is accurate, but landmark selection is carried out by a company rep or a biomedical engineer. Once again, the surgeon is blinded to it. Hence, probably we see literature like this. The take-home message here is what they have mentioned in the conclusion. The relationship between implant position and patient outcomes is unknown, and a consensus on ideal surgical targets for optimal implant survivorship has yet to be established. Why? Because most of the times what happens is that systems which have accurate imaging and landmark identification is controlled by company rep, or we have systems which are inadequate in terms of sagittal or axial plane. And that is why we have not been able to establish ideal surgical targets for implant survivorship and function. Here's another commentary saying much the same thing. Effectively, what it is doing is we are probably exchanging outriders without clinical benefit. That is, we are reducing outliers in the coronal plane, but we are exchanging them for complications without clinical solutions. Because we are exchanging them with complications like increased operative time, risk of infection, and thromboembolisms. Probably 3D templating is the way to go. Why? Because it is a CT-based accurate image capture. Landmark identification is performed by the surgeon in all three planes. The other factor which is quite often overlooked is choosing the right implant. We know that overhanging of more than or equal to 3 mm in at least one zone can lead to a twofold increase of risk of knee pain, more severe than occasional or mild, at the end of 2 years after surgery. And we know that this is fairly common. This was another study from Europe saying much the same thing. Oversizing in at least one area was found in at least 66% femurs and 61% tibials. Thus, a planning system which cannot factor in this variable is inadequate. The planning system should be able to help us accurately plan for the least bone loss and form of least cuts in all three planes, as well as help us in deciding bone coverage or implant overhang besides the position to mimic the natural curves of the bone. Another important variable. Where does accuracy come from? Does it come from planning or does it come from instrumentation? This was an excellent systematic review and meta-analysis carried out recently for shoulder arthroplasty. Patient-specific 3D templating or planning may have significantly influenced accuracy versus the actual patient-specific instruments themselves. One study found no significant differences between 3D planning and PSI, although both improved accuracy significantly. They go on to say that Three-dimensional preoperative planning can possibly make surgeons more cognizant to the deformity, such that they make subtle adjustments based on their plan that actually increase surgical accuracy versus the use of the physical guide itself. Probably we need more studies on this. If we look at the direction we are moving in technology-aided TKR with advances like computer navigation, image-derived instrumentation, and robotics, we can see that we are moving from either no planning or planning by a non-orthopedic person to very precise execution at a huge cost, both in terms of time and money. Where should we be going? Very precise planning to fairly precise execution with a simple solution. This was Albert Einstein's quote. I fear the day technology will surpass our human interaction. The world will have a generation of idiots. Advantage of 3D augmented surgery is that image capture is a CT based system with an accuracy within 1 mm. The landmark registration is by the surgeon is accurate in all three planes. It allows the surgeon to choose the best position for bony gap balancing, as well as allowing the surgeon to choose a personalized implant from a variety of off-the-shelf implants. And we have simple, modular, reusable instruments. Thus, there is an ideal post-COVID era digital technology, which is a web-based 3D augmented planning platform with modular and reusable image-derived instrumentation, which reduces operative time and improves OR efficiency. Thank you.